Hi, today we're going to talk to one of our favorite physical therapists, Jonathon Myers of Southland Physical Therapy. We have referred many patients to him and very happy with the excellent level of service and care that he provides, and was gracious enough to be on our video podcast. John, why don't you tell us a little bit about your background, education, and training?
Yeah, of course. Well, thank you for having me. I'm really excited to be here. I've really enjoyed seeing your patients. They all speak so highly of you. But for me, I graduated physical therapy school about 8 years ago. Went on to get a specialist degree called your OCS, which is for orthopedics. So I took a second licensure exam, got my OCS, went on to further specialize in shoulder injuries. Throughout my career, was lucky enough to open up Southland Physical Therapy here in Santa Ana. We've been open for 3.5 years now, and we're flying. So I'm really excited to be here.
So you have a branch office too, or
Yeah,
no?
we actually have 4 clinics. We have one in Santa Ana, one in Costa Mesa, one in Irvine, and one in Long Beach.
Now, do you go to all 4 of them, or you're primarily in Santa Ana?
I'm primarily in the Santa Ana location.
So I know the interest you have in specialty is shoulders, which we like to evaluate and treat. So let's talk about a patient that comes in with shoulder pain and they've really not seen anybody. They decide physical therapy is the first step. But by the way, and I always tell patients, that's the first step. So we have patients come in and want to get an MRI because they said their shoulder hurts a lot. And I tell them honestly that, listen, regardless of what your shoulder MRI shows, the very first step we're going to recommend to you is to go to physical therapy, because you may get treatment and your condition may improve and you may not need an MRI. And so in our opinion, physical therapy would be the first step for evaluating and treating a shoulder injury. So patient comes in and tells you I have shoulder pain. What are the steps you go through in assessing and providing a treatment plan for somebody?
Yeah, one of the interesting things about shoulder pain, especially compared to a lot of other injuries, is that it tends to happen without any specific cause. The vast majority of shoulder injuries that I see are people who come in and just say, you know what, I wasn't doing anything, I didn't earn this injury, and over the last year I've been getting more and more pain at the top of my shoulder or the front of my shoulder, and now I can't exercise, or I'm struggling to reach the cup out of the cabinet. And the interesting thing about the shoulder is that it's the most dynamic joint in your body. It's the most unstable, most movable joint in your body. And for it to function correctly, there's a lot of things that have to work. And if they don't, you start to put all the stress on all of those different tissues in your shoulder. So patient comes in, first thing we do, get the history. What's going on? What do you feel? And I'll tell you, if I have a patient come in and they're in this position automatically and they tell me, I'm having pain at the top of my shoulder when I reach overhead, we've almost got it figured out, because you already know that shoulder girdle is not moving appropriately. You're pinching on some things you don't want to pinch on. They've probably reached overhead 10,000 times, and now we're degrading on some of those tissues. So we go through the exam, do the special tests and things to really isolate which of those structures is injured, and then look at the strength and the mobility of the shoulder blade and the shoulder itself and how the chest muscles are moving to see where those restrictions in motion are occurring. And again, the reason that I love the shoulder is because if you can correct those, and they can correct pretty quickly, you can get a lot of result very quickly.
Even when I do surgery, the successful outcome depends on the type of rehabilitation that they get. And I have had the opportunity to work with therapists where the results of my surgery were outstanding, and others where the results were not good. And maybe I do blame the physical therapist for lack of improvement. So I think it's highly dependent. Let's say I have a painful right shoulder. I just have onset of shoulder pain. I played volleyball last weekend and was serving, and then I just noticed my shoulder now is very painful. So what are the steps?
One of the very first things I ask my patients that I find to be extremely diagnostically helpful is I say, use one finger and point to where your pain is, because it tells me almost immediately what structures I need to be suspicious of.
My pain is here.
Yeah, and that shows me right away, okay, maybe I'm thinking labrum, maybe I'm thinking biceps tendon, whereas if they point to the top, maybe I'm thinking, supraspinatus as part of the rotator cuff injury. So that starts to lead me down the path, right? I'm already formulating kind of what's going on. You've told me you play volleyball, so I'm thinking overhead athlete. Something probably got pinched, but let's see where our deficits are. So the first thing I'll do is just general range of motion. I want to see how you're moving. So I'll say, go ahead and put your arms out to the side for me, thumbs up, and all the way up as high as you can go. Perfect. Go ahead and come on back down. Watch how you're moving. I'm going to ask you to go straight forward, and I'm going to ask you to do exactly the same thing. Perfect. Go ahead and come back down. Now see you. Okay, range of motion looks pretty good. A little tight. I think maybe the suit shirt is restricting you a little bit, but nothing that I'm terribly worried about just watching you do this. Next thing I'm going to do is check your general strength. So I'm going to have you put your arms up just like this. I'm going to come over. Oh, I'm going to push you down. Hold up, 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 up. Very good. Arms straight forward for me. Thumbs up. Just like this. Hold that right there. Don't let me push you down. And I'm really looking for differences side versus side. Arms at your side for me just like this. Hold that right there. Don't let me rotate you out. Push into my hand. And the other direction. Push out for me. Perfect. We'll do the same thing here. Push in. Push out. Good. Bend them for me. Let me see your biceps. Nice. Pull, pull, pull. Bend them. And push into my hands. Perfect. And relax. Now I've got an idea of, okay, just generally your rotator cuff, at least your external and internal rotators, are doing their job. Okay, perfect. So we move into our special tests. So I'm going to take your arm forward. The first thing I'm going to ask you to do is, right, impingement. I'm thinking possible impingement syndrome from what you put. So I'm going to ask you to cross your arm just like this, bring your elbow kind of down towards the middle here, and I just want you to bring it towards your nose. And really what I'm looking for is pain. Does this reproduce the pain in that area that you are having your problem? If yes, no, okay, we're moving on. So then I'm going to check your supraspinatus tendon, which is the most frequently injured of your rotator cuff muscles. So I'm going to have you here, thumb down. I'll have you hold up towards the sky for me, please. Resist me. And I'm going to ask, is there any pain? Now, what I'm looking for in this case is there pain here? Because one thing you have to be very careful to differentiate is, do you just have pain in general, or do you have pain in the spot that you should be feeling this if this test is positive? I like to move into what's called the speeds test here. So I'll have you palm up just like this. Hold this up. Don't let me push you down. Beautiful. And oftentimes they'll say, oh yeah, that kills me. And I'll say, okay, let me take a look. I'll flip this down. And I'll say, okay, same thing. Don't let me push you down. And if this is a positive test, just relax. What I'll see is that this position feels much, much better than this palm up position. Oftentimes this test, what's called your speeds test, is one of my better differentiators between biceps tendon or rotator cuff tendon. There's some tests that can be done and that we do also do laying down. One's called Apprehension, the other one's called Relocation. I'm sure you've heard of these tests before. They're probably what I would consider the meaner tests in this world, where you rotate the arm back and you say, does that hurt? And then if they say yes, I would then push on their shoulder and push down to stabilize and see if that takes their pain away. There's this really awful test that I would never use called the surprise test, where then you just take your hand away and see if it still hurts them. Don't ever do that to your patients. If you're a clinician, that's a terrible thing to do. But really what we're testing for there is anterior instability or maybe a labral type injury. Now, if I take all of those tests and findings, if I've looked at your middle back thoracic rotation, generally I'll take a look at your shoulder blades, see really where they're sitting, but also how they're moving, it really paints the picture of me of where is the injury and why did it occur. And so when I'm explaining these to my patients, especially for impingement syndromes, almost always, the problem is that the shoulder blade muscles are not functioning appropriately, the chest muscles are a little bit too tight, or the rotator cuff is not doing its job, right? So we talked a little bit earlier about the shoulder being the most mobile joint in the body and therefore the most injured in your body. And a lot of things have to happen when you reach your arm overhead to make it so you don't cause yourself any injury. So you have your arm bone and it sockets into your shoulder blade, right? And you have what's called your rotator cuff. I know you've heard of such a thing. There's 4 muscles that make up your rotator cuff. One on top kind of initiates this motion, one on front and 2 in the back. The one on the front pulls your hand in, the 2 on the back pull your arm out. But really what they do is they work like a sling. So when you go to reach your arm overhead, they compress your joint to add some stability and they help pull it down a little bit so you're not pinching through all of this stuff. Now all of that has to happen when you're reaching overhead. In addition to that, your shoulder blade when reaching overhead has to be able to rotate, tip backwards, and elevate, which further creates some room in here, which can be stopped if the shoulder blade muscles aren't strong enough, or if these chest muscles are pulling your shoulder blade forward. I think the best way to really understand this is if you sit up nice and tall with me here, Dr. Moheimani. If you sit up nice and tall and bring your arm overhead, it's very easy. Go ahead and come on back down. Now, if you slump a little bit, kind of like mom says not to do, and stay in this position and try to bring your arm overhead, you will immediately feel those tissues just bumping together between your arm bone here and your shoulder blade bone on top. And so if we can eliminate those issues, oftentimes we have patients who come in with these impingement syndromes, and just by priming the muscles that are supposed to do their job, they go, oh, that's amazing. I feel so much better. They're not healed. It doesn't work that fast. But if you force the muscles to do their job, it takes their pain away. It tells me right away, this is what needs to be done. Fix the mechanics, symptoms get better.
So now I come in, and 2 weeks ago, I had a rotator cuff repair and a bicipital tenodesis. I come in with my sling. I've already had surgery. You did see me before and did some therapy on me, but it didn't work. And MRI showed a rotator cuff tear, and my doctor repaired it 2 weeks ago. What are the steps that you do in assessing me? I'm very frightened because I don't want you to move my arm. It's still painful. What should we do next?
I mean, at 2 weeks, the number one concern is protecting that repair, right? The last thing we want to do is injure that repair. So a lot of what I'm doing at that point, and I'll be honest, 2 weeks is about the earliest we ever see these patients. A lot of what we're doing is, one, educating them, right? Like you said, you have a lot of fear. Let me help alleviate your fears. Let me help answer all of your questions. Soft tissue is one of the things we do, the massagey type stuff. Maybe some taping if there's no open wounds or anything from the surgery, to just try to support the shoulder and try to limit the things that are causing you pain right now. Educate you on things you can do at home to reduce the pain. Oftentimes they have post-operative exercises, which at that point are still optimal for them. We'll go over those with them to make sure they're doing them appropriately, to make sure nothing is feeling wrong, and then kind of set the stage so that when they come back next week, they're ready for the next stage of this, right? But at 2 weeks, I wouldn't even really range the shoulder a whole lot. I would just let it.
So now, let's say we're at 4 weeks, and what is your plan at this point?
At 4 weeks, I would definitely move into some very gentle passive range of motion, right? We're entering that phase where we're protecting the shoulder, but what I'm trying to do is maintain what we have. Because again, the shoulder has this tendency to freeze up relatively easily. And if you're having a lot of pain, you're in a sling, you've been told by your orthopedic, be very careful with your arm, don't take it out of the sling unless you're doing X, Y, and Z. Some of our patients are really gung-ho and they will not move out of that sling for weeks. And what happens is that we get to the point where we can start moving them and there's just no motion to be had, right? That's scar tissue. So